Hello, everyone, and thank you for joining today's webinar on children's HCBS billing. Before we get started, I'm going to run through just a few quick logistics. So we are hoping to have time for Q&A during this webinar, so please submit your questions via the chat, and please make sure to send them to me, the host. If the chat is not already visible on the right-hand side of your screen, you can access it by hitting the little thought bubble on the bottom toolbar. And again, please chat in your questions, and we will hopefully have time to take some questions at the end. Additionally, we would like everyone to know that the slides in the recording will be posted to our website, and that information and timelines are current as of the date of this presentation. Finally, this presentation is not an official document. For full details, please refer to the provider and billing manuals. So our agenda for today is to go through the HCBS overview, fundamental requirements, continuity of care, and then to get into the billing for HCBS. So today's webinar will be focused on billing for HCBS. And with that, I'm going to hand things over to my colleague, Ann Cuppinger, who is going to begin our presentation.
Hi, everyone. Thanks for joining us. So we're going to do a quick overview of HCBS services and some of the fundamental requirements that you'll need to keep in mind if you're planning to bill for these services. So as many of you know, HCBS services are an array of services designed to be provided in non-institutional settings in order to help children and families remain together and for children to stay at home and in the community. The services are governed by a set of principles in terms of how we hope they'll be delivered so that they're family-driven and youth-guided, culturally and linguistically appropriate, and that they take into consideration the wishes and preferences and vision of the family members and youth who are involved. The services need to be individualized based on the child's health and developmental needs, and that all of these services will be incorporated into the child's plan of care. So what you see here is a list of all of the HCBS services. These are formerly, some of them were available only in specific children's waivers. They've now all been aligned into this one children's waiver. And the hope there is that it will give families, the best access that they can have to the services that are appropriate for their child's needs. So just a quick review of the timeline as it relates to today's presentation. As of October 1st, the 1915C Children's Consolidated Waiver Services will be carved into managed care, and also on October 1st, children enrolled in the waiver will be mandatorily enrolled in managed care. So a few fundamental requirements for providers to keep in mind. First of all, in order to bill Medicaid for these services, you have to be a designated provider. And that involves completing an application for designation with the state. There are 3 services for which you do not have to be designated, and those would be environmental modifications, vehicle modifications, and adaptive and assistive equipment. If you have questions about designation, there have been webinars on designation, and there's also a designation mailbox, and you can contact them to get more information. So also, in order to be paid for delivering a Medicaid service, providers need to be enrolled in Medicaid, and prior to delivering a Medicaid service to a particular child, you will want to be sure that that child is enrolled and active in Medicaid, and you'll also want to know what plan that child is enrolled in so that you bill the appropriate managed care plan. Claims will not be paid if the claim is submitted for a child who's not enrolled in Medicaid, or if that child has not been determined to be eligible for HCBS services, or if you perchance submitted the claim to the wrong Medicaid managed care plan. The other thing that's important is that you, as a provider agency, need to be in a contract with a Medicaid managed care plan. So that is a process that you will reach out to the Medicaid managed care plans who are enrolling children that you serve, and make sure that you have a contractual relationship with them and that you're credentialed with that plan. In the event that a child requires services, that there may be situations in which you'll work out a single case agreement. If a child, for example, is not able to receive a service within their network of the plan that they're enrolled in, they can work out single case agreements with providers to deliver those services. And the reimbursement is the same regardless of whether it's a single case agreement or a regular contract. And to that point, the plans are required to pay state rates, government rates, and that is required from the date in which these transitions take place for a minimum of 24 months. Claims can be submitted electronically through plans portals or on paper. It is really important that the appropriate claim form be used. There have been some situations where people are not using appropriate forms, and that leads to denials, so double check the forms. And each service has a unique rate code. It's also a common question that we get is, what if someone receives multiple services in the same day? And if that's the case, and the same CPT code is being used but a separate rate code, all those services would be payable. So there are some, when you get to the point of submitting a claim form, there are some required fields. Not every plan requires exactly the same fields, and on the CTAC-MCTAC website, you may want to look up a billing tool. There's a link to it on this slide and also at the end of the presentation. What that tool allows you to do is hover over the different fields on a claim form and learn exactly what information is required for that field and who is it required by. So it's fairly specific in terms of what each plan requires. What you see here is a list of minimum required fields. We encourage everyone to engage in claims testing with every plan with whom you are in contract. And that will be something that you'll want to do even if you've done previous Medicaid billing. You'll want to do it for these HCBS services to make sure everything's going smoothly. So just a couple other notes on claiming. Plans will not pay claims if they are submitted without applicable rate code, CPT code, and modifiers. The modifiers are a little tricky for people, and I guess it has been coming up somewhat frequently that not all the modifiers have been on the claim forms, so that's something you're going to want to take a look at. There is a billing and coding manual available on the DOH website, and that has all kinds of specific information about all of these codes and exactly what you need to do to bill for specific services and what the limitations and requirements are for each service. So I encourage you to take a look at that. Providers have to adhere to timely filing guidelines, and the plan also needs to adhere to timely paying guidelines, so that they are required, if the plan is submitted electronically, required to adjudicate the claim within 30 days, and if it's submitted on paper, within 45 days. Obviously, if there are errors in the claim, that will take a little bit longer. So if the provider does not have a contract or a single case agreement in place with the plan at the time the service is delivered, the claim can be denied. I think it's important to mention if anyone has any challenges in terms of claims, the state is really encouraging you to reach out as soon as possible so that they can help work out any issues that might be going on. So there are some situations in which you'll be submitting fee-for-service claims. Those will be done through eMedNey. And if you have questions about eMedNey, there's a webinar that will provide you with some additional information on CTAC's website, and there's also training on eMedNey's website. So if multiple services are provided on the same date, this might include services from the same program type. For example, a child might receive an evaluation and have a family counseling session, or they might receive both an individual and a group session, or services might be provided by different programs. If these services are allowed per the service combination grid, which is also available in that billing and coding manual, they will both be reimbursable as long as they're billed using the appropriate rate code and CPT code. So I would encourage everyone to take a look at that billing and coding manual and at those service combination grids so you understand better when services can be provided in combination. And again, there's only certain combinations that are allowable, and when multiple services are available to a family, it's really a matter of having a conversation among providers and with families and youth about which of those services is most appropriate to meet their needs. So HCBS services are intended to be provided in settings that really are natural settings for children and families. So obviously the plan is individualized. That will look different for each child and family, but in general they should be provided in the least restrictive setting possible to achieve the desired outcomes, and that includes frequently at home and in the community where the child lives, works, and engages in social activities. So I'm going to turn it over to Hope, and she's going to talk a little bit about continuity of care.
Hope, you might be on.
Consumers, I'm sorry, can you hear me?
Yes, now we can hear you, yes.
Okay. I wanted to spend a little time talking about the protections that we put in for consumers with this transition of children's services. Many of you know that the children's transition actually began in January of this year with the advent of new state plan services. They're listed here on this chart, which is OLP, PSR, and CPSC. And as we are rolling these services in, one of the first level protections that we do is that we do not allow managed care plans to conduct utilization review. Another way to say that is they would not be looking for a medical necessity of the services provided to transitioning enrollees, people who are receiving these benefits for the first time through the plan. So the freeze on utilization review for the services that carved in on January 1 was for 180 days. We did allow extra time for that first carve-in. Our normal freeze period is for 90 days. So you'll see the subsequent services carving in, the state plan services that carved in on July 1st were for 90 days, starting from July 1st, running up through October 1st. The same thing will happen for the carve-in that's happening October 1st. There will be no utilization management for HCBS that's newly provided to children in managed care plans. From October 1st through January 1st. For the new benefit for crisis intervention that's scheduled to begin soon, that is really, there's no UR for crisis intervention at all. That means there's no prior authorization required. So that continues on infinitum. And then the last service that youth peer support services coming in January 1st, that will also have a 90-day freeze. Now, what does this mean for providers? It means that you should expect that you will still have to have a contract or a single case agreement with a plan in order to get paid for services, but you should not see requirements from the plan for prior authorization during this window of time. However, it's really important to understand the distinction between that. If you are a provider and you are serving and enrolling in a plan that you do not have a contract with, you will need to still reach out to the plan to make sure that you are loaded properly through a single case agreement on the plan system. Otherwise, your claims may deny when you hit that plan system. So if we can go to the next slide. We also built into the children's transition protection for each individual child that is transitioning, and that's what you see on this slide. So for children who are participating in the 1915C waiver, as these changes have been imposed for the different benefits coming in over time, we did say that anything that was listed in the plan of care would not be subject to utilization review by the plan. The plan would not be able to suggest changes to the level of services provided or deny services that are included in the plan of care for 180 days from the start of the coverage. So you can see for the services that came in July 1, those state plan benefits that came in for the children in the children's waiver, there's that 180 days protection against changes to the plan of care. And that includes any service that is part of the children's transition or long-term services and supports that these children might receive. So, for example, if you have a medically fragile child who has private duty nursing in their plan of care, this same 180-day freeze on any changes to the plan of care would include those long-term services and support. And then you can see coming in October for the HCBS carve-in, as plans become responsible for the home and community services through the children's waiver, there is this same 180-day protection on the child's plan of care. And that really does give a chance for everything to shake out, for providers and plans to get used to working with each other, for everyone to understand the services that the child has been authorized for and why those services have been authorized, and just gives a chance for everybody to come on board with what that child's particular needs are. And then the third section here with these dotted lines looks a little different because we also built in over the next 2 years, as any transitioning child who might be being served through fee-for-service today, if something happens and they become enrolled in a plan later on, not just in October 1st, that same 180-day protection will kick in for anybody who's transferring from fee-for-service to a managed care plan within this 24-month window. They will have that 180-day protection on their plan of care. And then the last bullet that we built in is a 24-month, again, this 24-month period for a child who is in a current episode of care for behavioral health treatment. They are seeing a provider, they're in active treatment, and there's a definition for this in the manuals. They can continue with that same provider for that course of treatment for the next 2 years. So I think the next few slides pretty much just walk through what I've just talked about off the grid. So you can see it's just sort of repeating what I just said. No UR criteria pretty much for every new benefit coming in for the first 90 days, particularly for HCBS. Continuing to authorize services in accordance with the plan of care for the first 180 days. And that would, let's see. So, this third bullet here is really speaking specifically about the frequency, scope, level, and quantity and existing providers that are indicated in that plan of care. So as we approach 10-1, most providers will be approached by plans to ensure that they have that provider loaded up on their system so that these claims can be paid. If you do not hear from providers and you know you're serving a child who's enrolled in a plan and providing HCBS services, please reach out to the plan yourself to make sure you're loaded appropriately on their systems. And as we had mentioned earlier in the presentation, to do some claims testing to make sure there's no surprises come October. You can go to the next slide, and I think this is just more, the last piece describing the episode of care. And I think that's it for that. So I'll turn it over to the next speaker.
Great, thank you, Hope, and this is Boris. And so just one follow-up, just wanted to make sure, so in addition, of course, to making sure providers are loaded appropriately, as Hope talked about, and have contracts or single case agreements, I know I always encourage also providers to talk to plans even when they know they're fully loaded, have contracts or single case agreements, but also to make sure there's ongoing communication, especially around the individuals that are transitioning, making sure the plans are aware, who you're serving, and so forth, because that information is also helpful to the plans, even during the period of no authorization or utilization management requirement. Would you say, Hope, that's a good suggestion or recommendation for providers to talk about also the population they're serving?
Absolutely. So I think, any information exchange or good communication between the plans and the providers would only help.
Excellent. Thank you. All right. So thank you, Caitlin and Hope. My name is Boris Vilgorin. I'll take us through the rest of the presentation today, and then, as mentioned, we should have and hopefully we'll have time for Q&A. So please feel free to continue submitting questions. I know we've already gotten a couple of questions coming in, so please continue doing that. As Caitlin mentioned during the introduction, our goal is to really focus on billing for this presentation. The next part, as highlighted here, will focus on each service specifically and its kind of billing rules or guidelines, and both. Again, we can't say enough about the manual and making sure that you constantly refer back to the manual, because that is the official document, and has more comprehensive and extensive rules. One of the things that I know Ann mentioned during her presentation is about CPT codes and rate codes. So one of the things we'll go through in each service is also highlighting those codes for you. and making sure that that information is available. But again, it's also, once again, in the manual. So let's start with our first service here is the Caregiver Family Support and Services. Just jumping right into kind of the billing component of these. The Caregiver Family Support and Services could be provided both on individual and or group services. So you are able to do it in both, and one example that Anne uses is exactly that when you talk about if if two services happen on the same day. Again, you can have the services to individual, you can have a group of two, or you can have a group of three. The services are billed in 15-minute units, so that's important to note that, and there is a limit to 3 hours or 12 units per day. So as we kind of talk through that. The next slide, what we'll highlight here is in regards to the codes that was mentioned earlier in the presentation, but specific to this service. As you can see, the rate codes here are 8003, 8004, and 8005. So it's important to note that the procedure codes, also sometimes referred to as CPT codes, also sometimes referred to as HCBS codes, are the important components in the billing, and also the modifiers that Anne talked about that we have highlighted here. As I already mentioned, the unit measure here is 15 minutes, and the limit is 12 per day for the Caregiver Family Support and Services. The next service we want to review is the Prevocational Service. In similar way, it's also allowed as individual and group. And again, just like the previous service, you can do this in group of 2 or 3. It also is billed in 15-minute increments or units. The limit here is a little different. You have 2 hours or 8 units per day. The rate codes, of course, would be different because for each service, it does have its own rate code. You have the procedure code. It also has modifiers. And again, as mentioned, the unit measure is 15 minutes with 8 units per day as the limit on each of these services. Moving ahead to the Community Self-Advocacy Training and Support Service, as well allows you to do that in individual or group settings with the same rule of group of 2 or group of 3. Also following the 15-minute increments here, but it's important to note that the limit here is 3 hours or 12 units per day. With its own dedicated rate code system, procedure codes, again, or /CPT codes, HCBS codes. It has a modifiers associated as well, and once again highlighting that it's 15 minutes and 12 unit limit. Just moving us along through the services. The next one we have is supported employment. This service can only be provided, and I think that makes sense, on individual basis only. Also, though, covers it in 15-minute increments with 3 hours or 12 unit limit per day. In this particular case, we only have one rate code since it's only individual, which is 8015 with a procedure code of H2023 and a modifier of HA, and again 15-minute unit and 15-minute measure with a 12 unit limit per day. Moving to the palliative care services, again, just to highlight, this as a specialized medical care focused on providing relief of symptoms and stress or chronic condition or life-threatening illness. It is provided by a specially trained team of doctors, nurses, and so forth. And it is appropriate at any stage of chronic condition. So just wanted to highlight this. The children must meet LOC functional criteria and suffer from the symptoms and stress of chronic medical condition or an illness that puts individual at risk for death before the age of 21. So just highlighting the overview of that. The palliative care pain and symptom management Again, it's a pain and symptom management is to relieve and or control of the pain and suffering related to the illness or condition. These services are built in 15-minute units, and there is no limit as required by physician order. So here the physician provides the order and indicates how many units are allowed. The billing here particular for this has a rate code of 8016 with its own procedure code of 99347 and a modifier. And again, as mentioned, it is 15-minute measure with no limit as required by the participant's physician's order. Again, palliative care benefits may not duplicate hospice or other state plan benefits accessible to participants. So it's important to note that. Moving us along to palliative care bereavement. This service is to help participants and their families to cope with grief related to participants' end-of-life experience. This service is billed in 30-minute units, so as you can see, it's different. The service limits to lesser of 10 units per month or 120 units per calendar year. So again, important to note how this particular service is built in both the measure of units and the limits. The rate codes and the procedure codes are associated with this. The rate code is 8017, and the procedure code is 90832, with again the unit measure of 30 minutes and the limits that were described earlier. The palliative care benefit, again, as before, cannot be duplicated with hospice or other state plan benefits accessible to participants. Continuing with palliative care, the massage therapy, again, this particular service works to improve muscle tone, circulation, range of motion, and address physical symptoms related to a child illness. This service is built and are built in 15-minute units. It does have a limit of 72 units per year. So again, it's important to note that. Again, the rate codes associated with the massage therapy and palliative care is 8018, and the procedure code is 97124, with its particular modifier of TJ, and as mentioned, again mentioned, with the unit measure of 15 and a limit of 72 units per year. And again, important to note this is an annual limit. And as with other palliative care, again, it cannot be duplicated with hospice or other state benefits accessible to participants. Palliative care expressive therapy. This service is related to art, music, and play therapies that helps children better understand and express their reaction to their illness or condition through creative and kinesthetic treatment. This one is in 15-minute units as well as a measure, and this one has a limit of 48 units per year. The rate codes that are associated with expressive therapy is 8019, the procedure code is 96152, and the modifier is TJ, again with a measure of 15-minute unit and 48 units per year. And as before, it has duplication criteria here to pay attention to. So one of the other respite services is planned respite, a service that provides planned short-term relief for family caregivers that is needed to enhance the family caregiver ability to support the child's functional, mental health, substance use disorder, and so forth. This service could be provided both in individual and or group services, so it's important to note that. There are two individual versions of this in regards to how many hours, and it's divided by how many hours. So you have planned respite individual that goes up to 4 hours, and planned respite individual that goes over the 4 hours. You also have a planned respite group that allows it to go up to 4 hours. So again, pay very close attention to that breakdown when we talked about planned respite. The services are billed in 15 minutes unit for individual, again, for up to 4 hours. and groups. When we talk about the individual services that are over 4 hours, those are billed are in per diem per day, and so we need to highlight that. And coming back to the individual services, there is a limit of 16 units per day, and we'll review this again in our next slide. So again, as in other types of services that are similar that allows you to do individual and group, you have 3 different rate codes to indicate if it's up to 4 hours individual, over 4 hours, or if you are providing a group service, and associate rate codes, procedure codes are modifiers. The unit measures are either 15 minutes if we're talking about individual that's up to 4 hours, it's per diem for over 4 hours, and of course in 15 unit measures again for group service. And you have a limit for the individual that's up to 4 hours, which is 16 units. You have a limit on over 4 hours, which is 1 per day. And for the group, again, you have 16 units per day as your limit here. So important to highlight that. Another respite service is crisis. Excuse me, and this service is a short-term intervention strategy for children and their families or caregivers, which is necessary to address a child's behavioral health, developmental, or medical crisis or trauma, and of course including acutely challenging emotional or medical crisis in which the child is unable to manage without intensive assistance and support. The crisis respite service is individual service only. It's broken down into 3 different areas. You have, again, based on the hours that are provided, you have crisis respite up to 4 hours, more than 4 hours but less than 12 hours, and you have more than 12 hours but less than 24 hours. So pay close attention to that. Services are billed in 15-minute units for respite that is up to 4 hours, and there is a limit of 16 units per day. And the services that are billed per diem for respite more than 4 hours, so both of the 2 other categories would fall into here, and there is a limit of 1 per diem per day. So let's look at the rate codes that are associated and other codes here. Again, since there are 3 different excuse me, services, you do have 3 different codes, both rate codes, procedure codes, and modifiers. As I mentioned about the unit measures, you have 15 minutes or per diem, depending on how many hours are provided. And you also have the limits that vary between 16 units or 1 per day. Again, pay close attention to the hours and which service you're providing to the individual. Moving along to the day habilitation service. This service is, to assist the acquisition, retention, or improvement in self-help, socialization, and adaptive skill, including communication and travel, that regularly takes place in a non-residential setting. Habilitation is divided into individual and group services. Again, the group is the group of 2 or group of 3. Services are built in 15-minute units, and there is a limit to 24 units per day. It's important to note that group and individual day habilitation cannot be billed as overlapping services. They have to be distinct and separate. Supplemental services are not available to individuals residing in certified residential settings. That's because the residence is paid for staffing on a weekday, evenings, and any time on weekends. And children have a maximum daily amount of services that are available to individuals based upon their residence. So individuals residing in certified settings are limited to a maximum of 6 hours of non-residential services or its equivalent, which must be commenced no later than 3 p.m. on weekdays. So again, please pay attention when we talk about day habilitation and the setting the individual might be in. The rate codes are very much broken down to, like previously, based on individual, group of 2 or group of 3. Same with procedure codes and modifiers. The unit measures for all 3 are the same. They're 15, and the limit is 24 units per day. Community rehabilitation covers services and supports related to the person's acquisition, maintenance, and enhancement of skill necessary to independently perform ADLs, IADLs, and/or health-related tasks. These services may not be duplicative of any services that may be available under Community First Choice option. It is divided again into individual or group, and as before, a group of 2 or 3. And as similar to they have, it is 15-minute unit measure with a 24-unit per day limit. Has its own rate code breakdown based on individual versus the type of group. Procedure codes, modifiers as we have here, indicated, as well as, again, the unit measure and the unit limit per day. Environmental modification, we're moving into slightly different approach and service here, but again, wanted to cover here. This service provides internal and external physical adaptation to the home or other eligible residents of the enrolled child, which are identified as necessary to support the health, welfare, and safety of the child. In most instances, a specific type of environmental modification is a one-time benefit. However, in reasonable circumstances, a second modification may be considered of funding. Vehicle modification. This service provides physical adaptation to the primary vehicle of the enrolled child who are identified as necessary to support the health, welfare, and safety of the child, that enable the child to function with great independence. Adaptive and assistant equipment, again, it provides technological aids and devices which enable him or her to accomplish daily living tasks that are necessary to support the health, welfare, and safety of the child. So it's important to pay attention to kind of the overarching descriptions and what the services are meant. In this instance, when we talk about both all of the environmental vehicle modification, adaptive and assistant equipment, the LDSS will be responsible for the authorization of, again, EMODs, VMODs, and AT in accordance with the child's plan of care and this administrative directive for the children participating in children's waiver. Again, it's important, and I know mentioned earlier about the plan of care. Just wanted here to highlight that all of the services here that we're talking about, need to be included in the plan of care. So it's important to highlight that. For individuals enrolled in Medicaid managed care, once a service the individual is receiving is added to the benefit package, the LDSS will coordinate with the Medicaid managed care plan to share information about authorization and facilitate a smooth transition of services with no gaps in service delivery. And accessibility modification limits only those services not reimbursable under CFCO, State Medical Plan, Medicaid State Plan 1905A of the Social Security Act, or other federal state funding streams. Continuing with environmental and vehicle modification, adaptive and assistant equipment, the contracts for environmental vehicle modification, adaptive and assistant equipment may not exceed $15,000 per year without prior approval from LDSS in conjunction with New York State DOH or the managed care organization. The state may consider exceptions when medically necessary, including but not limited to, of course, significant change in child needs or capabilities. It's also, please note, that these services approval process that began prior to April 1st, 2019 will continue to be processed and paid for under the procedures in place at the time the request was initiated. So again, please pay close attention in regards to this particular timing and in regards when something was requested. We also wanted to provide, because there's a lot of information that's out there and available around these particular services, again, environmental, vehicle modification, adaptive and assistant equipment. So as you can see, we have a number of links here that go into much more detail and much more comprehensive in description and guidelines in how to move this forward. So please, when the slides become available, please take advantage of this resource, and please make sure that you access these links and information that they all provide here. One of the last services that we have on the list is the non-medical transportation. Just to highlight, this service will continue to be billed fee-for-service for members in the health home. Medicaid managed care plan approves POC and forwards the completed New York State DOH POC grid to the non-medical transportation for child's HCBS, the transportation manager. And so that's the process for members in the health home. The process for the members that are not in the health home, the Medicaid managed care must complete and update as needed, of course, the non-Medicaid medical transportation grid and forward that to the transportation manager who will work with that grid. And we also provide a link to that grid here for your reference when the slides become available. Hope mentioned, and I know in other, and Ann mentioned the combination, service combination grids. What we wanted to provide here is, again, a link, not just to the manual, but specifically to highlight the link to the service combination as it relates to especially services provided on the same day, but in general, getting a sense of which services and their combination are allowed and are not allowed. So please take advantage of that. So one of the things as we pivot and want to make sure we have plenty of time for questions, and I know we had quite a few already come in, so please feel free to continue submitting those questions. So this completes our kind of formal part of especially focusing on the billing and overview of the billing in other areas that we talked about, continuity of care and a general overview of HCBS. We're going to be moving into our Q&A section. I know there are a number of questions that are coming around. There are three in particular that we wanted to highlight and address that we get a lot, both I know the state gets and we get at MCTAC. So we wanted to highlight and provide the answers for. We're also going to talk about resources that are available in this slide deck. But before we get to the resources, let's just talk about a couple of questions here that we got. So one question that comes up, I talked a lot about limits. And so one question we get a lot, are the limits hard limits? So again, the billing manual actually outlines them and talks about the limits, but in acknowledgement of the need for checks against fraud and abuse, but not to ensure a client's access to services, the service utilization in excess of the annual claim limits, and soft unit, and soft being in quotations, unit will be based on medical necessity and subject to post-payment reviews. So documentation of medical necessity is always important, so make sure you have that, but especially in this instance, documentation of medical necessity for extended duration must be kept on file in the client's record. Please refer to the UM guidance for details on annual and daily limits. Another question we get is, how do we handle no-shows? Providers, for example, driving to a location and the individual is not there, spends that time. All of the HCBS services requires a face-to-face for the billing to occur. So unfortunately, and therefore no-show is not billable. Another question that we get a lot is, can a provider bill for a service when the child is not present? So some services, for example, Caregiver Family Support and Services is a great example, allows you to meet with the collaterals and families without a child. So the answer for some of them is definitely yes, but for others might be no. So again, please refer to the manual for more guidance on this to make sure that you're following the billing rules and guidance that have been put forward by the state. I will just highlight, we will not go through detail here, but as I've mentioned, you will have access to all of these additional resources in addition to the links we already talked about. And of course, we also always provide links to our tools that Ann talked about, for example, the billing tool. We also have the matrix and so forth. More resources and information that folks might have in regards to. We also have a list of email resources, as Ann mentioned, especially around if you have billing issues that are coming up that you would like to talk to somebody. Here are some of the ways you can contact our state partners in regards to those questions. And with that, I think we'll turn, the last 13 minutes or so of our time to the Q&A. I know we got a lot of questions. So while I've been talking, I don't know if any of our state partners had an opportunity to look at those questions and jump in on any of them, or we can also jump on some of them. So please, while I'm trying to organize myself here, please feel free to jump in and answer any questions that are appropriate. All right. Okay, so let's see, we just needed a couple of seconds to organize here. And I also, again, will invite our state partners to jump in if I'm missing anything or if we're missing anything. So one of the questions that we got, excuse me, if a child is enrolled with health homes programs, will we be able to bill for HCBS services for these children if a LOC hasn't been completed? Our understanding is children cannot receive children's HCBS until they have been determined eligible for the children's waiver. So including HCBS LOC determination and approval from capacity management and space availability, of course, as we talk about HCBS, is needed. So again, it's important that that is part of the process in regards to receiving those services. Just being enrolled in the health home, doesn't automatically make somebody eligible for HCBS, and thus doesn't automatically allow for that individual to receive HCBS services. So I just wanted to highlight that. Not sure if anybody from the state would like to add anything to it. Okay, just trying to see, we have one that's, see if we have a couple of others. So again, our goal today is focus, on the billing questions and billing issues that are coming up.
So, Boris, this is Hope, and I know that there was a question, it's not really related to billing, but there was some concern over mandatory enrollment. Mm-hmm. So I do think it's important just to let folks know that children who need to enroll as of October 1st with this change have already received a letter from New York Medicaid Choice, which is our enrollment broker. The state is not imposing auto-assignment requirements this fall. So there's plenty of time for children to be able to select a plan if they did receive one of these letters. And if anybody has a question about their status, they can certainly have that discussion with their care manager, and we can work through whatever anybody's individual question is.
That's great. Thank you, Hope. So another question we have here is about, a network adequacy potential provider shortage in some areas. And can managed care organization contract with other providers. So one, it's important to highlight, and I know Ann during her portion talked about this, that only state-designated providers can provide either CFTSS or HCBS, but in this instance today we're talking about HCBS. So it's important to highlight that it has to be, you have to be a designated provider to provide HCBS services. Plans, of course, are always required to help and work with, if needed, even out-of-network access, even if they are not contracted. But again, the provider still needs to be designated. They might not have a contract with a managed care company, but they still would need to have that designation to provide these services. So I think that's kind of the answer here, and the message is, so as we move forward, the plans are working with designated providers, and I know they're trying hard to bring folks into the network, but at the end of the day, that's the rule, is the state designation, so it's important that. We have a question about same-day services, so we have a question, can the services be at different times in the same day, or do we need to do the service all at one time? And the answer is no, you do not need to do services all at one time. There could be many different versions. I know Ann talked about one. It could be done by 2 different providers even, or agencies. The family and the child gets the service. It could be done by the same organization. You might do one service maybe in the morning, one in the evening. So there is no particular rule in regards to, do they have to be back-to-back or not? So it's important to note that. So thank you for that question. But they do not have to be done all at once. There's a question in regards to limits. Service limits are between all different service types within the HCBS service, or are they separate? For example, can you have 12 units per day of individual and 12 units a day of group? Which would be a total, or you can only have 12 a day regardless of individual or group. So one, right. So I guess before I answered, I want to see if anybody from the state would like to jump in and answer that question. All right, so I'll give it a go. Go ahead. Sorry, I thought I heard somebody. I'll give you my understanding here is each service has its own limit. So if you are providing 2 services on the same day, you are allowed those limits per each of those services. So I believe that's the answer here, and I'm not sure again if.
And I think the question might have been, for example, if you're providing a service that has both an individual and a group option, does the service limit apply for that service cover? In other words, if the service limit was 12 units, anything you do, whether it's individual or group, of that service cannot exceed 12 limits. So you don't have 12 units for group and 12 units for individual within that service for a particular service. I think that might have been the question.
Great.
Yeah.
All right. Thank you for clarifying that. Just looking through other questions, just trying to keep it to, again, focusing more on the billing component and seeing if we...
There are some questions on the E-mods and the vehicle modifications, and our understanding is that those questions are covered, the answers to those questions are covered in the webinars that are listed that are linked in the PowerPoint slides. If there is a question that you don't feel was answered in those webinars, you can let us know, or you can email the appropriate mailbox to find out more specific information if that's necessary. There are quite a few webinars on those services linked in the PowerPoint presentation.
Great, thank you, Ann. Again, just to clarify, there was a question about can you bill individual and group on the same day, and the answer is definitely yes. You can definitely bill individual and group on the same day. Just seeing if there's other billing questions that are specific.
So, Boris, there's a question about foster care children and billing for those children. So at this time, children who are in direct care of the district, this is mostly upstate, they're in direct care of the county, those children are already enrolled in plans. So as the service becomes covered by plans on October 1st, the billing for those children will change, and you will bill the managed care plan because they are enrolled in the plan. However, most children in the state are in the care of volunteer foster care agencies. Those children will not be enrolling in managed care October 1st. That part of the transition will not take place until February 1st, 2020. So there are no changes for children in the care of a volunteer foster care agency.
Got it. Thank you. Thank you for clarifying that. Appreciate it. All right, and I think just wanted to see in a couple of minutes that we have left, if there's another question or two that could be answered. All right. Anything additional from our state partners that you would like to?
So, Boris, there's a question on are there yearly limits on services? So the question that keeps coming up is around respite and planned respite and crisis respite. And the grid that they're referring to is the Appendix C in the manual, and it's the concurrent authorization grid. So that wouldn't occur until plans are ready to review based on the continuity schedule that we discussed today.
Yeah, excellent. Thank you. All right, so I think we maybe have time for one more, and again, I'll ask our state partners to see if there's any additional comments, feedbacks, or questions you would like to clarify before we conclude this webinar. All right. Well, with that, I think I'll thank everybody for presenting, especially Caitlin for running this webinar in the background and doing the intro, Anne and Hope. And thank you for everybody for joining. As was mentioned, this is being recorded, and both the webinar and the slide decks will be available with all the resources and links that we have mentioned earlier. And again, please continue utilizing the manuals that were provided by the state as the tool to clarify some of the questions. And so thank you, everybody, and enjoy the rest of your day. Take care.